55-year-old woman came into the emergency room with a blood glucose of 24, a heart rate of 38, and a blood pressure of 60. Her husband had found her unresponsive in their bedroom that morning. Paramedics had been pushing dextrose for 15 minutes. None of it was working. Despite calcium gluconate, despite glucagon, despite high-dose insulin and dextrose, despite intravenous lipid emulsion, she could not be resuscitated. The case was referred to the medical examiner not because the cause of death was unknown, but because at autopsy, the medical examiner couldn't find one. Every Sunday evening for the past 2 years, she had sat at the kitchen table and filled a plastic pill organizer for her husband. He had diabetes. He had high blood pressure. He took 5 medications. She knew them all. One Sunday in February, after she filled the organizer as usual, she opened the bottles again and swallowed what remained in each one. It's not so much when you spread it out across them, she thought. She swallowed approximately 110 tablets across 5 medications in 20 minutes. About an hour later, she started feeling lightheaded. She tells her husband she's going to lie down. Within 2 hours, she's sweating heavily, but her skin is cold. By morning, she's confused. Her husband calls out from the kitchen and she doesn't answer. By the time he reaches her, the drugs have been in her system for nearly 12 hours. Her pancreas has been releasing insulin all night, pulling sugar out of her blood faster than her liver can put it back. Her arteries, which should tighten when blood pressure drops, are stuck open. Her heart, which should beat faster when blood pressure drops, cannot beat faster. He shakes her shoulder. She doesn't respond. The paramedics who arrive know something is very wrong, but they don't know what. They give her sugar through an IV. It doesn't help. They begin chest compressions in the ambulance and bring her to the emergency room where we are now. Resuscitation is attempted for 40 minutes. She is pronounced. The case is referred to the medical examiner. There is no trauma. The organs look normal. The heart is normal size. There is no heart attack. There is no blood clot in the lungs. There is no tear in any blood vessel. There is no cause of death that can be seen with the eye. This is where the case becomes interesting because the medications she took don't damage tissue in a way a doctor can see. They kill by changing the chemistry inside cells. Once the cells stop working, the body stops. The diagnosis has been made not by looking, but by measuring. The forensic toxicologist takes samples from 4 places: blood from the leg, blood from the heart, urine. Although there isn't much, because her kidneys stopped working hours before she died, and pericardial fluid, which is the small amount of fluid inside the sac around the heart. The test comes back positive for 5 drugs: glympyride, metformin, amlodipine, hydrochlorothiazide, losatran, all 5 of her husband's medications, none of which had been prescribed to her. The first thing that killed her was hypoglycemia. Hypo meaning low, glyc short for glucose, which is sugar, and emia meaning presence in blood, low sugar in the blood. Glympyride belongs to a group of drugs called sulfonylureas. They work by telling the pancreas to release insulin. They tell it to release insulin whether or not there's any sugar in the blood for the insulin to act on. In a diabetic person whose pancreas is slow, this is helpful. In someone without diabetes, it is dangerous. When she swallowed too much glympyride, her pancreas released huge amounts of insulin into a body that didn't need any. Insulin pulls sugar out of the blood and into the cells. Her blood sugar fell, and fell, and fell. The brain, which runs almost entirely on sugar, started to fail. First confusion, then sweating, then loss of consciousness, then coma. Here is the cruel part. Glympyride keeps working for a long time. Even hours after she swallowed it, her pancreas was still being told to release insulin. This is why the paramedics couldn't fix anything by giving her sugar in the ambulance. As fast as they put sugar in, her pancreas pulled it back out. The second thing that killed her was calcium channel blockade. And this is where the case becomes a teaching case in forensic toxicology because of one number on the lab report that looks reassuring at first and isn't. Amlodipine is called a calcium channel blocker. Calcium channels are tiny doors on the surface of cells. When calcium flows through these doors into a muscle cell, the cell contracts. Amlodipine closes those doors. Without calcium, the cell can't contract. Arteries relax. Blood pressure falls. The heart contracts more weakly. Blood pressure falls further. In someone with high blood pressure, taking the right amount, this is helpful. In an overdose, it is deadly. Blood pressure drops so low that the organs don't get enough blood. Normally, the body fixes this by making the heart beat faster, but amlodipine also closes the calcium doors in the cells that control heart rate. The heart cannot beat faster. The body cannot fix the problem. The patient goes into cardiogenic shock. Now here's the part of the case that almost everything depends on. The toxicology results show that the amlodipine level in her blood was high, just as expected for an overdose. But the amlodipine level in her pericardial fluid, the fluid around the heart, was low. Lower than it should have been after taking that many pills. A medical examiner who didn't know what to look for might see that low number and think amlodipine was only a small part of what killed her. It was the biggest. Pericardial fluid sits right next to the heart muscle. For most drugs, after a person dies, the heart cells break down and release whatever drug was inside them. The drug then leaks into the pericardial fluid. So for most drugs, the level in the pericardial fluid is higher after death than it is before. This is called postmortem redistribution. It was first studied carefully in the 1980s by a forensic toxicologist named Graham Jones, who showed that drug levels measured at autopsy can be very different from drug levels in a living person, sometimes by 10 times. Before his work, courts assumed the level in the blood after death was the same as the level in the blood at the time of death. It often isn't. But amlodipine does not behave like most drugs. Amlodipine sticks to heart muscle. It binds tightly to the muscle and stays there, even after death. In this small science experiment, I take a kitchen sponge and put it in a glass of water with a few drops of food coloring. After a minute, I lift the sponge out. The water in the glass looks almost clear. The sponge is dark blue. If you only measured the water, you could say there's very little dye in the glass, but the dye didn't disappear. It went into the sponge. The sponge is still holding it. This is what amlodipine does in the heart. So the low pericardial amlodipine level was not evidence that the drug had left her body. It was evidence that the drug was still stuck to her heart muscle. At the moment of the autopsy, amlodipine was still inside the calcium doors. It had killed her by closing. A third drug was working alongside the first two. Losatrin keeps blood vessels from tightening. Hydrochlorothiazide is a water pill that makes the body lose fluid. In her husband, at the right doses, these medications kept his blood pressure under control. In her, at overdose doses, with no high blood pressure to push against, they emptied her circulation from the inside. She had less blood in her body. Her vessels couldn't tighten around what blood she had, and her heart couldn't pump it forward. 4 drugs, each one hiding the others. The low blood sugar caused sweating and confusion that looked like a panic attack. The low blood pressure made her feel warm, which hid the shock that was starting. The slow heart rate from amlodipine prevented the racing heart that would have warned her husband something was very wrong. By the time anyone could see she was dying, the chemistry inside her cells was already finished. The combination of a sulfonylurea and a long-acting calcium channel blocker is described in medical literature as nearly impossible to survive without fast treatment before the patient even reaches the hospital. The standard rescue is called intravenous lipid emulsion. It works by putting fat into the bloodstream that pulls fat-loving drugs out of the tissues. It has saved many people from calcium channel blocker overdoses. In her case, it was given, but it was given 40 minutes after her heart had stopped. By then, there was no circulation to carry it anywhere. Taking medication that belongs to someone else is the most common cause of fatal household poisoning in adults over 50. Most discussion of overdose deaths focus on opioids and benzodiazepines, and that focus is right, because those drugs kill the most people. But sitting on bathroom counters in most homes is a different kind of risk. The medications keeping a family member alive can, in the wrong dose, end someone else's life quickly and quietly. Sulfonylureas, calcium channel blockers, beta blockers, blood thinners, a spouse, a parent, a teenager who knows where the bottles are kept, can take a fatal dose without ever leaving the house. At autopsy, her heart looked normal. There was no heart attack, no clot, no tear. The pathologist examined the arteries, the valves, the conduction system, and found nothing wrong. The poison was inside the muscle of the heart itself, stuck to the very channels she had blocked. It was invisible to the eye. It could only be found by measuring the chemistry. The case was closed as a suicide by polypharmacy ingestion. Her husband, who outlived her, was prescribed the same medications for the rest of his life.